Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications at Africa CDC. I will be moderating this session. Starting off with the Director General of Africa CDC, Dr. John Kaseya, who will give us a situation analysis and then introduce other speakers and panelists on this session. Over to you, DG.
Good morning, good evening, good afternoon to all of you. Welcome to Africa CDC press conference on Mpox. Today, we are joining this call from Brazzaville, where we are attending the WHO Regional Committee meeting. But because Mpox is a major issue today in Africa, this is why we are maintaining our weekly updates to the media and the African communities. I think my colleagues, they will just present to you the 2 slides for us to see where we are with this outbreak. I don't know, Margaret, if we can project the 2 slides. No, the first one first, the second one, that will be the first. This is for this week. This week, as you can see, there are 22,863 cases, including 3,641 confirmed, and a number of deaths that were provided, 622. But what is new, if we compare with the second slide that is from last week, what is new is you'll see that we have a new country, that is Gabon, with first confirmed case. And we can go to the second slide. Can we have the second slide, please? Okay. Okay, that one. If you compare with last week, where we had 18,910 cases and 541 deaths, you will see there is an increase of around 3,953 cases from last week to this week, and 81 deaths. This is it's showing to us that the outbreak is still moving. We have an increase in terms of cases, but we want to be clear on that. We know the surveillance in Africa is still weak. We know that in many areas, we have under notification of cases. And this is why Africa CDC is deploying from next week 72 epidemiologists to go in all regions, all areas where we have cases, and to ensure first that we are supporting community health focus. We are supporting health focus in terms of notification of cases. And also, we are analyzing data because we know that there is also a data quality issue. In addition to supporting the lab network for more testing and ensuring that the data coming to national level and also to Africa CDC, we can have a kind of confidence on this, the quality of data. Then the second update I wanted to give you today is about what we did last week. As you know, last week we were in DRC. You can stop slide, please. It's okay, thank you. Last week we were in DRC, where where we have the epicenter of the outbreak. We had the opportunity to meet the Minister of Health and all partners we had the opportunity to meet the Minister of Finance, the Prime Minister, and the Head of State. What we got from DRC is a clear commitment that DRC is supporting the response against Mpox. We also got from DRC $10 million in addition to effort that they are doing to support the fight against Mpox. It's clear that DRC drafted a response plan, and during our meeting, we found that this response plan, we had to rework on that together and to have an appropriate and a response plan that is really showing the effort that the country is doing to contain this outbreak. We got another response plan from DRC yesterday, moving from 49 million to almost 700 million. You can see it's showing the ambition that the country has. But under this 700 million, we have around 400 million for vaccines. But this one will extract that from this budget because it will be a kind of in-kind donation thanks to the effort that Africa CDC and all partners are doing. We also had a meeting with a number of partners to continue to secure support for Africa. We had a meeting with almost 200 partners coming from various sectors: philanthropy, private sector, public sector, from Africa, from other parts of the world. And we got a clear message from all of our partners. They are supporting Africa and they are ready to provide appropriate support based on the continental response plan that we are finalizing. We had also a meeting with what we call the Foreign Ministry Channel for Global Health Security. That one, it was comprised by some global health ambassadors of Western countries. And we got also a clear support that they will provide what the response plan, the continental response plan will request. And they are waiting for this continental response plan. What also we got from them, the clear message about no travel ban to be applied to Africa. I think we got a clear commitment from all of them that there will be no travel ban against Africa. We wanted also to share with you that all of us, we saw this article from New York Times. This article from New York Times was talking about the issue related to WHO EUL. It means the emergency authorization that WHO is giving mostly for Gavi and UNICEF to procure vaccine. And with that, we had a meeting. I had a meeting with the Director General WHO, Dr. Tedros, yesterday, who confirmed to me that he already gave authorization to UNICEF and to Gavi to procure vaccine while the process, the WHO EUL process is ongoing with the Nordic vaccine. I think this is for me, as Director General Africa CDC, a good news because we don't want to see any kind of issue in terms of quick deployment of vaccine in Africa. That news was confirmed to me by the CEO of Gavi, and I know that we are working together now, Africa CDC, Gavi, UNICEF, WHO, to procure very quickly vaccines for African countries. I want also to update you on the continental response plan that we are developing. The continental response plan is ongoing. We are still working on that. And to date, we made huge progress. Let me be clear on that. What are we calling a continental response plan? Continental response plan has two components. The first component is the plan that we got from each country. And this plan is helping us to know what are needs from countries. We have time to work with each country and to assess the quality of their plan. This is like what we did with DRC to support them to develop an appropriate plan. And we are doing that with other countries. It will be a consolidation of all response plans from the 13 countries. In addition to that, we have also requests from other countries that are high-risk countries that are requesting some support. Will include that. The second part of the continental response plan is what all agencies and partners who are involved are providing for technical assistance. We have like WHO, UNICEF, Africa CDC, MSF, World Food Program, IOM, because all of us, we are playing a key role to respond to this outbreak. Responding to this outbreak is not just about Africa CDC. Responding to this outbreak is about all partners working together and supporting each other by considering the comparative advantage of each partner. We are clear on that. We are working on that. I think we made huge progress because some partners already shared their plan, because we already received the country response plan from all countries. By tomorrow, we'll finalize with the first draft that will be shared to the appropriate groups like the emergency consultative group. As we committed, we need to share with them for the input. Once we get the input, we now call for the governing board meeting of Africa CDC to validate this plan. And this plan will now be submitted to all partners in the same time. Africa CDC is calling for the meeting of the Committee of Head of States by around the second week of September. And this Committee of Head of State, some key partners will attend at the highest level. It will be an opportunity for our Head of State to endorse this continental response plan, while partners, they will also say how they are contributing to respond to this response plan. I think for today, I wanted to give you these highlights on where we are moving, what we did, and we are at your disposal for any question that you think you need to ask us. Over to you, Margaret.
Thank you, DG. We have a number of questions already on the chat. I would start there and then we can move to the other ones. So Alexander Winning from Reuters is asking, what is the latest on how many Mpox vaccine doses are coming to Africa, and from when and from who? African countries trying to buy doses directly from manufacturers, and if so, how are they funding that? What is the Africa CDC's advice on vaccines? Are they the only answer to containing Mpox outbreaks? What other specific interventions do you recommend? I will take just one more before you come in. The other question here asks about the diagnostic test for Mpox. Is there some work done to ensure viability and manufacturing of Mpox tests made in Africa? You can take those two, DG.
Okay, thank you. Let me start with Alexander questions. What is the latest on how many Mpox vaccine doses are coming to Africa? We have already secured 215,000 doses from Europe, European Union through ERA. In addition to that, you saw the tweet that we made yesterday after my meeting with the state minister, the French state minister, Madame Crissoula, that we are getting additional 100,000 doses from France using the same mechanism of ERA and Africa CDC. It means we move from 215 to 315. On top of that, we have 50,000 coming from the US. And we have 15,000 coming from Gavi. Then we are also working with other partners. I had a nice chat with the Minister of Health from Germany. We have we have hope that Germany will contribute. They are waiting for the needs that we'll share with them. And we have also support from other partners. I can say for now, we are thinking about that total that I gave you. It means 215 plus 100 plus the 65 coming from US and Gavi. Now, you are asking if African countries trying to buy doses directly from manufacturers. Currently, what we are doing, we are putting all African countries' effort in one basket. And this is why we say we are finalizing the response plan, and we'll have this meeting in September, where countries, they will also pledge funding. But so far, what we are getting from the 10 million that we got from the AU, the African Union organ, we are using that to strengthen the capacity of the country to be ready to use vaccine when vaccine will be available. And what is the advice regarding, you are asking, are vaccines the only answer to containing Mpox outbreaks? For now, we have the first answer to contain the Mpox is to strengthen surveillance. We need to know who is suspected case. It means we need to strengthen the community-based approach. We need to strengthen the surveillance using our health system to ensure that we know all cases. The second one is about how to test most of these cases, if not all of these cases. This is why we need to confirm all cases, because we still, we can still have suspected cases that are not Mpox case. But I think you saw the letter I sent to all ministers. In this context, even if a test is negative, it doesn't mean that there is not Mpox. We need to be led by the symptoms that the person has and also the history of the person. If we have a person who was in contact with someone who has the disease, or a person who traveled to a place where the disease is, because there are so many reasons why the test can be negative. This is why we are calling our member states to pay attention on that. Now, regarding the other in addition to surveillance, in addition to the diagnostics, yes, we don't have currently for the Clade 1B, we don't have medicine. I think last week you saw me, I was with Professor Muyembe, who confirmed that a study was conducted where clearly the tecovirimat was not found important to be used in Africa. But the only tool that we have today is vaccine, and we'll start to use vaccine in addition to other actions that I described. Regarding the diagnostics, I think if I got you well, the diagnostics we want to ensure that in some countries we move from 18% of testing rate today to at least 80%. And this one means first we need to deploy the capability at, to decentralize this capability. And we need, it means in terms of a gen expert, in terms of a PCR, and we are also working in terms of antigen for rapid tests. We need also to train people. You saw us, we organized a training of trainers in DRC last week with Professor Muyembe and Africa CDC team to support those who are doing testing in the field. And then these colleagues, they will do the training of other colleagues who are at regional level. I think we are moving to make sure that in a country like DRC, as an example, Africa CDC is providing additional $3 million to ensure that all PCR and gen experts are ready to be used. We'll partner with other partners like Global Fund and others, Gavi, to ensure that we continue with this level of effort. Let me stop there and take another question.
All right, let's take the next two. Albarodi from SciDevNet, you have the floor.
Thank you, Margaret. I think you can hear me now.
Yes.
I've posted my questions on the chat, but let me say that, ask them here. So I would like to, if there's any updates on the Mpox vaccine tech transfer with Bavarian Nordic. So which countries have been chosen or manufacturer have been chosen? And what is the criteria Africa CDC applies to select these manufacturers? And what is the expected timeline for the process? Also, I would like to ask if there's expected demand when these manufacturers start producing, that there will be still a demand for vaccines for Mpox in Africa. Thank you.
Thank you. Let's take one more. Janice, you have the floor.
Hi, thank you for taking the questions. I wanted to firstly just ask about Burundi and Uganda. I see that cases in both of those countries have rapidly increased. And the Uganda one, the Uganda situation, I find concerning and interesting because it seems that the cases there are concentrated in 8 villages in the Busia district, which isn't particularly on the border with DRC. So it seems further afield, and it's being reported that that's mainly in children. So I was just wondering what your thoughts were on that. And linked to that, I'm trying to figure out if someone has had Mpox, does that mean that they've developed a certain level of immunity? And if so, how long does that usually last? I realize that this Clade 1B is pretty new and everyone's trying to figure out a lot of detail around it. But if you've got any sense of whether people who've had Mpox are likely to catch it again, and if so, how long are they immune for?
Thank you. DJ, you can take those two.
Yes, thank you so much. You know, for me, I have to say every day, our continent is not ready for another pandemic. We faced COVID. We didn't have vaccines, medicines. We didn't have even syringes, gloves, and were abandoned. Today, we are in a similar situation where we start to look for vaccine because we don't manufacture vaccine. This is why our discussion with Bavaria Nordic, now it's public, I think you saw the statement from Bavaria Nordic. Our discussion with Bavaria Nordic led for the transfer of technology to African manufacturers to start to manufacture this vaccine. We were transparent on the way to do that. And we thank Bavaria Nordic for this engagement that we had. What we did, we sent preliminary information to all African manufacturers with capacity to manufacture a vaccine. And 9 of them came. We had extensive meetings, Africa CDC, manufacturers, and Bavaria Nordic. And this tech transfer will lead for what we call the fill and finish. It means we'll get the technology, and with that, we start to manufacture the Mpox vaccine. I got a preliminary report that out of the 9 manufacturers, there could be only one with the capacity to manufacture this vaccine. I'm still waiting to have a debriefing with my team about this one manufacturer, and I cannot disclose the name today because I know, but I'm giving you just the process. For you, you have to understand it was an open and transparent process based on capabilities and capacity of each manufacturer. I'm happy that at least one manufacturer can do that. The question about the demand, if we still think that there will be demand, let me remind that Mpox is a zoonotic disease. And we have Africans in rural area living close to forests. And it means for us to contain this outbreak, we need to continue to have some quantity of vaccine to prevent another outbreak. We also know that currently Mpox becomes a sexually transmitted disease. That can lead also for us to continue to be more careful and to vaccinate maybe some categories of people can be at risk. We are talking mostly about sexual workers in some areas where we have this Mpox that is transmitted sexually. We also know that we have around 40% of our children who are in the eastern part of DRC, out of 100%, we have 40% who are children less than 5 years. And if you see, most of them, they have malnutrition. It means we'll continue to have a kind of demand to support the vulnerable children and people who can be at risk. I don't think that even for Mpox vaccine will stop with this current outbreak, but it will continue. This is why we are working with countries to know what can be the ideal quantity of vaccine they will really need to address the current outbreak, but also to support the program for the future. For your second question about Burundi and Uganda, and I will hand over to Dr. Ngashi, who's the incident manager for Mpox based in DRC.
Yes, thank you very much, TJ. Yes, on the question about Burundi and Uganda. In Burundi, there is a significant local community transmission already that is observed. That's what explains the fact that the number of cases is increasing rapidly. In about 4 to 5 weeks, Burundi has already reached 796 cases. I think that to show that this is a community level transmission, but similar to the picture in DRC, because it is the same clade 1B, we have 43% of the cases are among children below 10 years. In Uganda, we have now 4 cases. You notice that the transmission in Uganda has been much slower because these are cases that are imported from the DRC. That's why it is predominantly in the border areas. And again, just putting an emphasis on how we need to respond and strengthen the cross-border surveillance. Now, the second question was on the duration of the protection. That this is too early. This is too early, especially for the African community, because we haven't had vaccines before. But learning from the experience of the 2022 outbreak in Europe, I think what we see that there was still protection of people that were infected. That is the natural immunity. People that were infected at 4 to 6 months, I think there was still protection. And for those that had induced immunity, meaning following vaccination, they still had protection at 9 months. Yeah, but I think that's early. As you know, we're talking about 2022, 2023. More data is still being compiled. There's a lot to learn. And we'll also, very soon as we start vaccination in the African population, we'll also start the same study to be able to document also the duration of the protection in that population. Thank you very much.
Thank you very much. Let's take the next 2 questions. From the chat group, Chinedu from Associated Press asks that when do we expect the first doses of vaccine to arrive in DRC, particularly Congo? Will Congo still receive doses this week as anticipated? And secondly, have you seen any improvement in surveillance and treatment efforts? Internally displacement camps in Eastern Congo. Let's take one more from Sibeso from Zambia, ZNBC TV. He's asking if there's an increase in Mpox cases. Does this mean the borders on all Africa member states will remain closed, or will they still be open? We can take those ones first. Over to you, DG.
I hope you can hear me very well. Thank you. Yes, we are working with the government of DRC to ensure that the vaccine will land by next week in DRC. And we know also when we send vaccine, this is first a very expensive vaccine. Second, a vaccine that requests some logistics, even cold chain. Then want to make sure that when vaccine will land in DRC, we will not lose doses. Working with the government, and I know improvement is made in a number of areas for that. I think if I have to give you a specific date based on what we started to discuss with IRA and Bavaria Nordic, the 1st of September, we can send doses of vaccine in DRC. We'll give you more details in terms of the vaccination plan. This is what we are thinking to do, vaccine to become available from the 1st of September in DRC. Now, the question related to if there is an increase in terms of cases, if the board will still be open. I said it in my opening remarks. I said we are clear on that. When Western countries, they had Mpox as public health emergency of international concern, Africa didn't close borders for them. And we are calling for solidarity. We are calling for support. We are doing our best to contain this outbreak. And we are moving very well. We hope that with all effort we are putting in place, we can contain this outbreak. Then for me, I don't see for now any reason to call for border to be closed. No, borders are open. People will continue to drive, to fly from a country to another one, from a region to another one. And while we are doing our best to contain this outbreak. Over to you, Margaret.
Thank you, DG. Let's take the next two from the room. Carmen, you have the floor. Carmen, can you hear us? All right, let's move on to Sarah Jerving. You have the floor.
So Africa CDC and WHO Afro have worked on improving coordination on health emergencies in recent years, particularly through the JEEP program. Can you talk about how Africa CDC and WHO Afro are delineating roles in this outbreak to ensure there are no duplications in these efforts? And how would you say that this outbreak differs from previous major health outbreaks?
Thank you. Let's take the next one before DG comes in. Patrick Kahondwa, you can come in.
Thank you very much. I'm going to speak in French. Messieurs les DG, vous avez dit dans votre intervention que 72 épidémiologistes seront envoyés dans tous les pays touchés par l'épidémie. Personnellement, je suis en RDC et dans une zone la plus touchée, la province du Sud Kivu. Est-il possible, au fait, de mettre en contact... Yes.
Patrick?
Yes. Can I continue?
Yes, okay. Over to you, the DG.
Alors,
vous pouvez continuer?
Yeah, OK. Est-il possible de nous mettre en contact avec ces équipes qui viendront particulièrement en RDC pour suivre de près ce qu'ils font? Également, par rapport à la question de la vaccination, sur un besoin de 3 millions de doses que souhaite la RDC, ce n'est que 215 000 doses qui seront réceptionnées bientôt. Alors, comment Africa CDC compte accompagner la RDC dans l'atteinte de ses objectifs en matière de vaccination? Et quelles sont également les stratégies que vous mettez en œuvre pour éviter l'hésitation vaccinale comme on l'a vécu à l'époque de COVID-19?
Thank you. Over to you, Didi.
Thank you. Let me start with Sarah's question. I think if I got well, it's Sarah. Sarah, you are right. You know, we have a joint mechanism called Joint Emergency Action Plan linking Africa CDC, WHO AFRO, WHO EMRO, and now UNICEF, WECA, which means Western Central African region, and UNICEF, it means Eastern and Southern African region. This mechanism is helping us to coordinate all interventions that we are having to support our member state. But let me say something clearly and loudly. This is the first time that Africa CDC is declaring a public health emergency of continental security. And you know, when we declare that, there is also other mechanisms from our Africa CDC statute that we need to unlock. It means we need to unlock the governing board. It means we need to unlock the committee of states for them to continue to provide guidance and support. We are not just a technical organization. We are also a political organization, because our role as Africa CDC is to ensure that we are involving not only our member state, but at the highest level of the continent and the whole AU mechanism. This is why we decided together with partners to put in place one continental incident management team. Because it's the first time, you know, we'll expect some challenges on the way to have things moving and to work on more to be straightforward on the way we are doing our job. I think this is why we really thank our colleagues from WHO, from UNICEF, from MSF, from World Food Program, from IOM. All of us, we are coming together to put in, and IFRC, because I forgot IFRC, we are coming together to build this continental incident management team. That one will give us some lessons on how to manage other outbreaks in the future. I think we are moving, and I'm so happy on the progress we are making in this area. Regarding Patrick, I will answer in French, and I will also send a message to our brothers and sisters from DRC. Patrick, vous avez raison de dire que les 112 épidémiologistes que nous déployons doivent aller dans les zones où il y a vraiment un réel besoin. Et c'est ça d'ailleurs notre objectif, c'est de les mettre dans les zones où il y a les besoins. Comme je l'ai dit, nous avons des données, mais nous devons vérifier la qualité de ces données que nous avons. Nous avons vu des cas où les notifications ne sont pas au niveau optimal. Et nous avons vu aussi des cas où parfois on peut avoir un problème de données. Donc, voilà pourquoi ces épidémiologistes, en plus de l'appui qu'ils vont donner aux équipes des terrains et autres vont aussi s'appesantir sur la qualité des données afin que nous puissions avoir les données qui nous permettent de prendre les bonnes décisions. Puisque si vous avez les mauvaises données, vous allez prendre les mauvaises décisions. Donc ça, c'est... vous allez voir que dans les prochaines semaines, nous allons commencer à donner ce que nous pensons être des données de qualité grâce à cet appui. Mais c'est aussi une opportunité pour moi de parler à mes frères et sœurs de la RDC. Mes frères et sœurs, Mpox, ce n'est pas un mensonge. Mpox, c'est une réalité. Mpox, ce n'est pas une fabrication des politiciens. Mpox, ce n'est pas pour les business. Nous sommes africains. Nous sommes là pour diriger l'agence continentale pour préserver la santé de tous les Africains. Et nous avons sonné cette alarme puisque le problème est réel. Et nous avons été suivis par cela par l'OMS. Aujourd'hui, une des façons les plus sûres d'arrêter cette épidémie, en dehors de tout ce que nous faisons sur la communication, sur la surveillance pour détecter tous les cas, sur le dépistage, il y a le vaccin. Ces vaccins, comme je l'avais dit quand j'étais en RDC, est le même qui a été utilisé aux États-Unis et en Europe. Ce vaccin a été donné à plus de 1 200 000 Américains aux États-Unis. Ce vaccin a été donné à des millions d'Européens. C'est ce qui a permis d'arrêter l'épidémie. S'il vous plaît, croyez-nous, nous avons fait toutes les études. Nous veillons à ce que la qualité de ces vaccins soit la même que ce que les autres ont reçu. Puisque les Africains, nous avons les mêmes droits que les autres. Africa CDC et tous les autres partenaires, nous serons toujours là pour nous assurer que vous recevez le vaccin de qualité et que nous stoppons cette épidémie. Rappelez-vous que tout le monde est à risque. Et donc, protégeons ceux-là qui sont déjà affectés afin que nous autres ne soyons pas affectés. Ça, c'est un message que je lance à la population de la RDC. J'ai été là-bas, j'ai commencé à sentir quelques résistances, mais soyez sûrs que nous ne donnerons jamais un vaccin si nous ne sommes pas sûrs de l'impact positif que cela aura sur notre population. Merci. Up to you. Back to you, Margaret.
Thank you, DG. Let's take the next two. Carmen, you can come in. Carmen, if you can hear us.
Yes, I can hear you now. Can you hear me?
Yeah, we can hear you.
Thank you so much,
Go ahead.
Margaret. Thank you for doing this. I just wanted to go back on the vaccines that sort of like are ready to come into the DRC in the near future. The US has been saying since at least a month ago that the 50,000 Mpox vaccines that they've committed are ready to go and that they're waiting on the formalities on the DRC side to be done. But DG, you said that the ones from Europe most likely will come starting September. So I was wondering, what's the holdup with the vaccines from the US? Is there anything else that needs to be done on either side for the vaccines to be shipped to the DRC? And if I may, I have a second question on protecting children. Obviously, the Bavarian Nordic vaccine has not been licensed for children. And there's so many cases of Mpox in the DRC and in Burundi, as we heard, in children. So what is sort of like the plan to protect children, to sort of like ensure that this doesn't spread to more children, given that at least the Bavarian Nordic vaccine hasn't been licensed for them, but we know that I think the WHO has said that the Japanese Mpox vaccine is licensed in children. Thank you.
Thank you, Carmen. Let's take one more. Gabriel Emmanuel, you have the floor.
Actually, that was very similar question to me. I was wondering about the specific considerations for the children, if they will be given the vaccine, and if so, you spoke about malnutrition in this population. What are the considerations given this population is different than where it's been used in the past? Thank you.
Over to you, DG.
I will hand over to the incident manager to respond to these questions.
Yes, thank you very much, DG. On the question on vaccine, the US vaccine availability, I think there were issues related to the request that was supposed to come from the DRC government. There are also issues related to the emergency use authorization and all the background documents that were supposed to be prepared. Now, we had the discussion this morning with Gavi team, because Gavi is also facilitating that process. And we're informed that as of now, it's like all the documentation has been already produced and shared by the Minister of Health. It's just a matter of now of really working with the US government on the transfer of those vaccines. As we hear that Gavi is also ready to facilitate that process, because they are bringing in an additional 15,000. They would like to add to the 50 to make the 65,000 doses that are coming. Now, on the issue of the protection of children, the government of the DRC had requested from Japan a donation of the LC16 vaccine, which has been tested and proven efficacious in children. I think the negotiations, from what we hear from the government, are quite advanced. They had requested at least 2 million doses from there to protect children. But in the meantime, what we are promoting is the basics of Mpox prevention, meaning hygiene practices with the washing of hands, avoiding contact with any person that is sick or has symptoms. Really, all the basics, IPC in health facilities, because children are also getting it in health facilities, safe sexual practices to also prevent mothers getting infected and then ending up with mother-to-child transmission. And finally, is also the environment of the children, where they are crowding, like in schools, that we are also pushing the introduction of those hygiene practices, but also the education of children and the teachers to be able to identify the children that might fall sick much early and take them out of the crowd, out of the other children, and take them to the health facilities for diagnostics and isolation. But I think that's where we are. Those basics remain for the protection of children. And then in addition to that, the negotiations are quite advanced. We had a meeting I think last week with the foreign ministers. I think we heard the foreign minister of Japan was collected, and they confirmed that they have received the request and they are preparing for that. I think that's why the country stands right now. Over to you, Margaret. Your microphone is muted, Margaret.
Thank you. Let's have the next two. Britton, you have the floor. Britton, you are muted. Okay.
Yeah. Hello, good day. May I ask you that, according to what we know, PCR is most suggested way to do the diagnosis. How do Africa CDC consider about lateral flow rapid test? Will you use this kind of way to do the testing in some of the area?
Thank you. Let's take the next one from Mohammed. You have the floor. Mohamed, you're muted.
Ok, bonjour tout le monde et merci pour les différentes présentations. Moi, je suis Mohamed des services vétérinaires de la Guinée. Je voudrais savoir Mpox étant une maladie zoonotique, quelle est la place accordée à la collaboration multisectorielle One Health, c'est-à-dire qui inclut les différents acteurs? Voilà, je vous remercie.
Thank you. Over to you, DG.
Yes, I will quickly answer to Mohamed's question and answer to Brayton's question regarding PCR and rapid test. We have so many people following us in Francophone countries. When a question is in French, I answer in French. La collaboration est non seulement souhaitable, mais elle est inévitable et elle est ce que nous sommes en train de faire. Lorsque nous avions commencé à parler de One Health, nous avions dit qu'il y a une interrelation entre la santé animale, la santé humaine et la santé environnementale. Vous allez voir que Mpox lie les trois aspects. Par rapport à l'environnement, on voit comment les changements climatiques affectent les comportements et des humains et des animaux. Et nous avons vu comment ces changements climatiques est un facteur majeur pour le déclenchement de la maladie. Nous avons vu, en ce qui concerne la santé animale, comment la maladie a utilisé des réservoirs naturels au niveau des animaux pour aller vers l'homme. Et maintenant, nous sommes en train de décrire des cas où c'est l'homme qui infecte l'animal. Donc, voilà un exemple clair d'une maladie qui nécessite un One Health approach. Voilà pourquoi, dans le cadre même de notre réponse, nous travaillons avec des partenaires qui sont responsables de la santé animale pour appuyer la réponse au pays. Donc, nous avons une approche holistique dans ce qui concerne les Mpox. Alors, Dr. Ngachi va vous donner des éléments en rapport avec les PCR et les rapid tests. Over to you, Dr. Ngachi.
Yeah, thank you very much, DG, and thanks, Britain, for that question. Testing remains a major challenge for many reasons, related to the equipment itself, related to the places, the locations where these cases are happening, the terrain that is extremely difficult, and then the sample transportation system, which in those places is really challenging. I think that's the reason why in the current thinking, there is really a push to have those rapid tests that could be placed in those places where it's very difficult to get the first screening before the entire process of getting the positive samples for confirmation to the reference laboratories. Now, we are working with Professor Muyembe with the ENRB. There are a number of tests that the different partners are offering to the government. And then the approach now is to have a validation process that will allow the ENRB to validate all those tests against the gold standard, which is the PCR test, to establish the sensitivity and specificities of those tests and make a recommendation. And what will happen at those rapid tests that will be proven really to be efficacious to help the cause will be most welcome for the reason that I've just explained, that the terrain is really challenging. And all the time that you waste time that you are still waiting for the confirmation, the patient is still at community, living in the community and transmitting the disease. And the best way to stop that it's early detection, where you can't get your PCR machines, the rapid test, that is a solution. But then the science has also to play its role to validate them before they are recommended for use. Thank you very much. Over to you, Margaret.
Thank you. Thank you.
Thank you, Dr. Ngachi. I'll take the next two from the chat. I have one from Eniola of Journal Freak. She asks, what possible economic consequences do you think the Mpox epidemic poses? And are there any attempts being made by the Africa CDC to ensure that we don't see COVID level economic consequences? That's one. The next one is from Cassandra in Bangkok. She says there's a case confirmed in the country at the point of entry in a European city. How can an individual protect against infection in an airplane? What recommendations do you have, and how can that be completely avoided? Over to you, DG.
Thank you. I will answer to this question by also providing, in addition to what Dr. Ngashi said, the question related to the consequence on the country's economy if we can avoid what we saw during COVID time. I will give you a quick example of a country. I was talking with the minister of Djibouti yesterday, and I was talking with the minister of Ethiopia. Ethiopia is importing mostly goods using the seaport from Djibouti. And on daily basis, you have around 1,500 transport trucks crossing the border on daily basis. That comes to 8,000 trucks as it was in 2020. And you can imagine if one of the countries is affected, the consequence will be huge for the economy, but also for the public health system of the affected country. I'm talking about the two countries, Djibouti and Ethiopia. This is why we are not running, but we are flying. We are doing our best in Africa to control this outbreak. Because if we don't control this outbreak, if that clade 1B, clade 1A, even clade 2 can continue to spread in other countries, we can have an extended outbreak. And don't forget that Mpox is listed as one of the 30 diseases that can become a pandemic by WHO. It means we need to do our best now to stop this outbreak. And we are doing our best to do that. Regarding how to protect ourselves, if there is a confirmed case, I think Dr. Ngashi already responded to this question by saying we have some measures that we can take at personal level, like washing our hands, like avoiding unnecessary contact, like for those who have multiple partners, to protect themselves using condoms, if this is what they think to do, to avoid, to be infected. But if you are in the airplane, if the question is, Mpox is an airborne, that is a disease that can be transmitted by air, I think there are still studies ongoing. We cannot confirm today this is the case. This is why WHO and the Africa CDC, we are not talking about masks today because we don't have evidence on that. But once we get some outcome of studies ongoing, we'll come back and we can provide guidance. Over to you, Margaret.
Thank you, DG. Leon from Nation Media Group, you have the floor.
Thank you very much. I have a number of questions. Number one, Kenya has only had 2 positive cases, all being truck drivers from Uganda. So many Kenyans are asking, why do we need vaccines when those cases, seemingly according to our government, have been isolated and handled? Because if we compare to COVID-19, there was much more epidemiological data that warranted for vaccines. And then I would love also to know on the question of DRC. DRC has forever had a logistical and administrative problems. How are we going to administer vaccines in that country? Thank you.
Thank you, Leon. Let's take one more. Albert Bernard, you have the floor. Albert?
Hello.
Albert, yeah, we can hear you.
Okay, please, I'm Albert Bernard Kumsin from Ghana. I'm a public health nurse. And my question has to do with Ghana. I think we don't normally hear about Mpox. You know, the condition is just in Africa here. And the likelihood that it will come to our country is very high. So I want to ask, have there been any processes or anything that is being done at our borders or anything that has concern with Mpox in Ghana here? And my second question is the vaccines. I don't know about the countries that have not yet recorded the cases. Or the vaccine be rolled out in these countries as well? And when are we getting our first doses? Thank you.
Thank you. Over to you, DG.
Yes, thank you. I will answer to the first question, and Dr. Ngashi will answer to the second question from our brother from Ghana. Yes, you know, the decision to deploy a vaccine for Mpox, even if we have only a few cases, is driven in several important public health considerations. You know, the first one, the government of Kenya will say, I want to prevent an outbreak. Because Mpox, like other infectious diseases, can spread rapidly, especially in population with close contact or in regions with limited healthcare infrastructure. Then vaccinating at-risk population, even when cases are low, can help to prevent potential outbreaks that could overwhelm the health system. We have also a decision that can be made because the government can consider that early vaccination can be a containment strategy, because by vaccinating people who are at risk, or people who are have been in contact with confirmed cases, that can help to prevent the virus from spreading further. And you know, it's driven by a number of other factors, like if the government can consider can cause severe illness, particularly in vulnerable population. I think we are advising the government, we are providing all necessary information to the government. They know their own context and they can make decisions. When you are talking about this truck drivers, but you know, from where they came, the country you are talking about, to Kenya, you don't know how many times they had to stop. You don't know how many people they went to shake hands. You don't know where they went to eat. You don't know what they did, because it was not just one stop, then they were tested positive. You know, and sometimes it's too risky for a government to let situation being like that without taking appropriate proactive measure. And vaccination can be this proactive measure. We are working together with the government of Kenya, and I think I can even fly to Kenya in the next 2 days to meet Kenyan authorities to discuss about how the country is approaching this vaccination. Regarding DRC quickly, yes, we know that DRC is a vast country with some logistic challenges, but we also know that DRC has a strong experience on vaccinating children and mothers against other diseases. And you can see the coverage for some diseases is high. Then we'll build on that. And we'll also support the country if there is any additional effort to be done to ensure that this Mpox vaccine will be used by people who need it. I will hand over to Dr. Ngashi for the second question.
Yes, thank you very much, DG, and thanks to the colleague about Ghana. I think not hearing much about Mpox in Ghana at this time is a problem on its own. Ghana had already cases that were under investigation, and Ghana neighbors like Ivory Coast do have active transmission right now. I think there are cases that are going on in Ivory Coast. That means that I think the risk is is much closer to home. I think that's the reason why it is extremely important that the education, the risk communication and community engagement be already started together with the surveillance, most importantly, surveillance at point of entry. I think that is very critical to put already those basic measures were in place. You can see the experience of countries that neighbor a country that is already affected. It's just a matter of time. I think if there is no surveillance, it's a matter of time when you consider the high mobility of populations between our countries, and neighbor Ghana is one of those. It is extremely important. And also when you look at the borders, also you have Ivory Coast is also neighboring Liberia, which has got also cases, and Sierra Leone, that just reported the case recently. It just tells you that for all those reasons, it is important that the preparedness of Mpox be already started in Ghana as soon as possible. Over to you, Margaret.
Thank you, Dr. Ngashi. I'll take the next two from the chat room. Kerry from Health Policy Watch has two questions. There has been a suggestion that Japan's KM Biologics. Kerry Callan from Health Policy Watch has two questions. There has been a suggestion that Japan's KM Biologics will donate its Mpox vaccine to Africa. Has there been any discussion with them, that is Japan? The second question is, what percentage of those with Mpox in DRC in particular are children under the age of 10? Let me take one more question. Claudia has a question on the profile of cases. Can we affirm the transmission route changed between Clade 2 and Clade 1 and Clade 2? That's a question. Over to you, DG.
Thank you. I think the first question, Dr. Ngashi already answered that, but he can maybe articulate again more on that. Yes, and Claudia, your question about Clade 1, Clade 2, let me tell you what we did and what is making us worried. Having 4 outbreaks in one. Because today we have clade 1A, we have the clade 1B, we have the clade 2A, we have the clade 2B. It's a combination of all of these clades. In some countries, you have 1 clade, 2 clades, 3 clades, and that one, we really don't know. You know, the issue with Mpox is not COVID. The issue with Mpox, there are so many unknown zones. While we are coming with some tools like vaccine, and you saw, just if you take the example of tecovirimat, I was talking with a minister of a country from ASEAN region today. He was telling me we procured a number of doses of tecovirimat by thinking that it can help us if we get the clade 1B. But I shared with him the study is clearly showing that it will not help you. We don't know everything. We are still working while we are supporting countries to stop this outbreak. We are working to make a number of studies. My colleague, Papa Mosoka, who is the acting director for Science and Innovation in Africa, CDC, even is organizing a meeting in the couple of days with WHO, CEPI, and NIH to launch enough studies, new studies, in addition to what others they are conducting, like in DRC. We will come back to you when we have any, but keep it in mind, there is a risk of mutation of virus with all of these clades in Africa. Even in the world, I saw a question from Duduzile, who said he did a quick Google search that reveals that Mpox is called African disease. No, Mpox is not an African disease. Mpox is anywhere in the world. If there is a journalist calling Mpox Africa disease, it's just wrong and it's inappropriate. Then Dr. Ngashi maybe will come up about Japan because he already responded, but maybe.
Yes, thank you very much, DG. Mpox is in over 110 countries. It's not only an African disease. Africa has got 55 countries only. And now on the question about the proportion of children below 10 years in DRC, it is 35%. I think the DG gave that number when he was responding. And then on Japan, I confirm that the government of DRC has already submitted the request. The Ministry of Foreign Affairs of Japan has confirmed that they have received the request and they are working to provide the requested vaccines to the DRC. Over to you, Margaret.
Thank you, Dr. Ngashi. Let's take the next two. Necho Gabriel, if you can hear us, you can come in. Necho, can you hear us? You're muted. All right, let's move on to the next person. Nyanga, if you can hear us, you can come in. Nyanga, can you hear us? You're muted.
Oui, oui, Nyanga, je suis là, je vous écoute.
Nyanga, yes. Come in.
Ok. Oui, j'ai ma question. Merci beaucoup au directeur. Et la première question était de savoir si Africa CDC pense mettre une équipe multidisciplinaire pour les contrôles de qualité à tous les niveaux de la chaîne d'approvisionnement des vaccins. Donc, parce que c'est un vaccin qui coûte d'abord cher. Qu'est-ce que Africa CDC pense pour sauvegarder la qualité de ces vaccins tout au long de sa chaîne d'approvisionnement? Ça, c'était la première question. La deuxième question, c'est par rapport à l'exclusivité des vaccins du fabricant dont le directeur a parlé. Et quand on a des cas d'exclusivité, je ne sais pas comment est-ce que Africa CDC pense gérer les caprices du fabricant comme on aura affaire à un fournisseur exclusif. Donc, les caprices, tous les aléas qui nous seront présentés par les fabricants tous les aléas, pardon, qui nous seront victimes, tous les aléas, les caprices que les fabricants vont présenter, comment est-ce que Africa CDC compte gérer ces histoires-là. Enfin, comment est-ce que Africa CDC pense gérer les agents vaccinataires pour que les vaccins ne soient pas dégradés, pour que ça soit administré jusqu'au bout tout en gardant la qualité. Parce qu'au niveau des chaînes, des zones de santé, pardon, si les vaccinateurs ne sont pas bien formés, même si les fabricants fabriquent la qualité, fournissent la qualité, les vaccins peuvent se dégrader. Alors, comment est-ce que Africa CDC pense, ensemble avec le ministère de la Santé, gérer les agents vaccinateurs? C'était ça ma troisième question. Enfin, la dernière, est-ce que Africa CDC s'est déjà rassuré de l'état de la chaîne de froid à tous les niveaux, à toutes les zones de santé concernées? Est-ce qu'Africa CDC et les ministères se sont déjà rassurés de l'état de la chaîne de froid? Merci beaucoup. C'est ça. Merci.
Dr. Ngashi, could you mute?
Oui, merci beaucoup, Dr. Nyanga. Donc, à la première question, c'était de savoir s'il y a une équipe multidisciplinaire qui va gérer les vaccins pour en assurer la qualité. La réponse est oui. Nous avons une équipe d'Africa CDC déjà qui fait la logistique. Et en plus de cette équipe, nous recevons encore un renforcement de l'équipe de l'UNICEF qui ajoute 4 experts encore en logistique et en logistique de vaccins qui vont venir donc s'ajouter à l'équipe d'Africa CDC pour qu'ensemble, nous puissions accompagner le pays de bout en bout, c'est-à-dire pour assurer la qualité de vaccin depuis l'arrivée jusqu'à l'injection dans les bras. Donc ça, c'est quelque chose qui est déjà pris en compte. La deuxième question, c'est en rapport avec l'exclusivité du fabricant. Je pense que le DG l'a expliqué quand il a fait son introduction. Il a dit que la stratégie de Africa CDC est double. Il y a d'abord le besoin immédiat qui est de trouver des vaccins pour couvrir la population qui est à risque. Et en même temps, cela arrive quand Africa CDC est déjà en train de pousser un grand agenda de la fabrication locale des vaccins, des tests diagnostiques et des médicaments. Et que derrière ça, il y a une très grande négociation qui est en train de se faire, déjà même avec la compagnie qui fabrique les vaccins dont on parle, Bavarian Nordic, pour qu'en même temps, il y ait donc un transfert de la technologie qui permet aux fabricants africains donc de pouvoir prendre la relève pour commencer déjà à produire localement. Donc ça fait partie de cette indépendance pharmaceutique qu'Africa CDC est en train de pousser sur le continent. Il y a un travail qui a déjà été fait pour voir la capacité sur le continent et nous savons qu'on a au moins 9 plantes qui ont la capacité de production et au moins 3 qui peuvent commencer dès l'année prochaine. Donc, c'est vraiment quelque chose qui est pris parce qu'on sait qu'en trouvant d'autres fabricants, ça va nous aider à réduire les prix qui est pour le moment très exorbitant autour de 100 € par dose. Et puis, votre troisième question, c'est en rapport avec les agents vaccinateurs. Nous sommes vraiment conscients que c'est un nouveau vaccin que l'on introduit et qu'il sera extrêmement important comme on a d'ailleurs, on a collaboré avec les pays qui ont déjà intégré ça dans leur plan de riposte. Il y a la formation des vaccinateurs, donc à tous les niveaux. Il y a l'accompagnement des vaccinateurs pendant les activités de vaccination à travers la supervision pour se rassurer que la qualité des vaccins est maintenue. Bon, et puis, donc, à côté de ça, il y a une troisième dimension qui se fera sur la rémunération de ces vaccinateurs qui sera basée aussi sur la performance, c'est-à-dire le respect de tous ces principes de qualité qui se font. Et finalement, votre dernière question, c'était en rapport avec la chaîne de froid. Cette épidémie arrive au bon moment. Ces pays sont en train de sortir juste de la COVID. Il y avait eu déjà une cartographie de la chaîne de froid qui était faite pendant la COVID. C'est à ce titre-là que Africa CDC, avec d'autres partenaires comme l'UNICEF, avait travaillé ensemble pour renforcer la chaîne de froid. Donc, cette cartographie-là est en train d'être actualisée parce que les vaccins doivent être gardés à une température de moins 20 degrés. Donc, pour établir la capacité qui est déjà là. Mais déjà, c'est ce qu'on a trouvé. Il y a des équipes qui ont même visité physiquement, comme à Kinshasa, l'équipe d'Africa CDC était là à Kinkole pour voir la capacité qu'il y a. Et c'est sur la base de la recommandation que maintenant le pays a été jugé prêt à recevoir ces vaccins-là. Il n'y a pas que Kinshasa, comme vous savez, la RDC a beaucoup d'autres hubs à Lubumbashi, à Kisangani, et tout ça, ça fait partie de l'actualisation de la cartographie qui a confirmé effectivement que la capacité est là pour lancer la vaccination Mpox. Over to you, Margaret.
Merci, merci beaucoup. Je suis satisfait, mais je ne suis pas médecin, je suis logisticien de santé. Merci.
Thank you very much, Dr. Ngashi. We have 2 minutes left for the DG to provide closing remarks. Over to you, DG.
Yes, Margaret, thank you. I saw a question from our colleague from Jeune Afrique in the chat, who was asking if what kind of vaccines are we expecting in Africa, and type of vaccines, if I can summarize. I think currently we are talking about the genus vaccine. It means the Bavarian Nordic vaccine. We know we are also thinking about the tech transfer. We are talking about the what we call LC16M8. This is the Japanese vaccine. This Japanese vaccine, we know that there is a commitment to provide 3 million doses in Africa. And we know also that they submitted their dossier for the WHO EUL. It means the emergency authorization from WHO to use this vaccine. We also have what we call the BNT under 66. This is the BioNTech vaccine using the mRNA technology that is going through clinical trial phase 2 and 3 to ensure that the quality of the vaccine and the safety of the vaccine. Yes, maybe we'll have other initiatives, but we'll continue to communicate on that. Let me now thank all of you for this opportunity. As you know, we clearly said the Mpox is still a major public health issue in Africa, but also in the world. We are working together to finalize a strong response against Mpox. This response will also help us to build the system using the One Health approach. This response will also help us to ensure that we have capacity to manufacture our own vaccine. This response mostly, and the most important one, is today a testimony that Africa can lead a response and can be supported by partners. It's the first time that Africa CDC starts with an outbreak that we declare. It's the first time that Africa CDC is bringing all partners together to put in place what we call the Continental Incident Management Team. It's the first time that Africa will have one response plan and one budget. And also, it's a lesson because we are empowering our ministers to be the effective leaders of this outbreak, while we are bringing our head of state to strongly support the response. We know that next week, when we'll meet, we'll start to talk about vaccine in Africa. And we are excited that we can get this vaccine in Africa. We are doing our best. We have this deadline of 1st of September. It's not fixed. It depends on a number of factors, but we hope the week of 1st of September, we can get vaccine in Africa. I thank all of you, and let us meet again next Tuesday. Thank you so much for your support to communicate about the Mpox in Africa and the world. Back to you, Margaret.
Thank you, DG. Thank you, everyone, for joining us. We'll see you next week.